remind himself to Miss Vance at the Kirby location. But if they're still asking you, just make sure you remind them that we are having that raffle very soon, and they'll have another chance to get those shirts should they still want them. As of now, there's no plans to sell the shirts beyond this date. I don't know if they're going to offer that at a later time, but for now, they're just sticking with the raffle unless you got your orders in today. All right. Any questions on that before we get rolling here? All right. So let's get into our next chapter, everybody. This will be our last chapter before our next test that is on Friday. This is going to be chapter 16, where we talk a little bit more about electrocardiograms, a little bit about heart function, but we're going to leave it a little broad overall, not get into extreme detail, more so just the points that you need to know for registry purposes and for your career. We can spend a whole semester on just the heart because it becomes so complex. There's so much to it. There's so much anatomy. There's so many functions, so many little intricate details, but we're going to leave it a little less complicated and just focus on those main things you need to focus on to answer those registry questions should they pop up when you're taking that registry in a couple of years. Speaking of registry, I got to start studying for mine. I got to take a CT registry next month. Not looking forward to that, but ready to rock it out. All right, let's see here, everybody. Get everything pulled up. All right, I have any Legend of Zelda fans out there? That is from the Legend of Zelda. Since we are talking about the heart, I thought about having a heart container from that video game. Just thought it was appropriate. I always got to throw my video game stuff in there whenever I can. So this is chapter 16, and we will be talking about basic cardiac monitoring, not advanced. This is very, very basic, very, just the bare minimum what you need to know as far as electrocardiograms go and some of the anatomy within the heart. Well, let's go ahead and move through it. This is a very short chapter. This won't take us very long to get through. All right, so when we talk about basic cardiac monitoring, first thing we're going to talk about briefly here is what we call cardiac output. Now, we determine the cardiac output by measuring two key factors within the heart. There's, of course, the heart rate, which we talked a little bit about last chapter, but also what we call left ventricular output. Also goes by the synonymous term of what we call stroke volume. Now, heart rate is measured in beats per minute, BPM. The stroke volume is going to be measured in milliliters per beat. Focus more on the beats per minute. That's the numbers I need you to know for that. When it comes to stroke volume, I don't need you to know the numbers on that, but just know what it is. And that stroke volume measures blood volume and vascular resistance. Blood volume and vascular resistance. And that does take place primarily in the left ventricle when we talk about stroke volume. Left ventricle. Heart rate is determined by nerves and by hormones. Nerves and hormones work together to provide that constant heartbeat, to get that homeostatic balance that we're looking for that heart to pump correctly and filter that blood throughout our entire cardiovascular system. So once again, that cardiac output is determined by those two factors right there, heart rate and stroke volume. Stroke volume is primarily measured in the left ventricle. Heart rate is measured throughout the entire heart itself. Heart rate moves upon the basis of nerves and hormones. And stroke volume is measuring blood volume, vascular resistance. Okay, so for electrocardiography, guys, when we talk about electrocardiography, what is that exactly? That's what we call simply an electric assessment of the heart's ability to perform its vital function. And its vital function is pumping blood throughout our entire body, providing blood to the entire body, keeping us alive. That is based primarily on that electrical assessment because we actually measure those electrical waves because the heart does beat based on electrical signals given by the nerves. And like I said last chapter, you'll see this used synonymously in next to each other. They mean the exact same thing, whether we're talking about EKG or ECG. Both terms refer to the exact same thing. That's that electrocardiography, electric assessment of the heart's ability to perform its vital function. And once again, that vital function is, of course, pumping blood throughout the entire body, providing blood to every organ, every area of our body, from fingers to toes, and making sure that we stay alive and function well, keeping that homeostatic balance of our blood flowing through the entire body and all its surrounding systems. Okay, so for cardiac function, like I said, what's the main function of that heart? Of course, it is to pump blood through the vessels to all of our vital organs and all of our tissues. If they do not receive blood, they essentially die, such as if a limb stops receiving blood, it has to be amputated because that limb becomes dead. It needs blood to survive. It maintains what we call cellular perfusion. What this simply means is that we're providing nutrients through the body and removing cellular waste. That's another function of the cardiac system. And generally, we're always going to require that systolic pressure to be greater than 90 millimeters mercury. That's what we need that systolic pressure to be at. If it's too low, it's going to throw everything out of balance. If it's way too high, it's also going to throw things out of balance. So we want to maintain, on general, that 90 millimeter mercury of systolic pressure to make sure that it is doing its proper functions throughout the body. If we're not at that systolic pressure, those functions we just talked about are going to cease and not work accordingly how they need to for providing blood throughout the body, and of course doing that cellular perfusion that we just spoke of right there in the middle. So we must have that systolic pressure to be on average at that 90 millimeters mercury for those functions to actually function correctly. Otherwise, we're going to get into what we call an arrhythmia. It can cause all kinds of issues throughout the body. There's multiple types of arrhythmias that people present with. Multiple heart conditions. Now, when we talk a little bit more about cardiac function, we're going to go briefly into some of the heart anatomy here. 4 major pieces of anatomy that you do need to know and know how to label, by the way, are the ventricles and the atria of the heart. So the heart is divided into a left and right section. On the left side of the heart, we do have an atrium and ventricle. Left atrium, left ventricle. On the right, we also have a right atrium and right ventricle. Remember, we are looking at the heart in anatomic position. Therefore, the left is over here in the red area. The right is over here in the blue area. So the ventricles are going to be that inferior portion of the heart, 2 inferior chambers of that heart. Left ventricle is right here. Right ventricle is right here. So draw on that. Here's our left, another color. Don't use red on a red heart. Bad idea. Left ventricle is right here. Right ventricle is right here. The left atrium is on the superior portion of the right side of the heart up here. The right atrium is on the right superior portion of the heart. So we have left atrium, left ventricle, right ventricle. We also have a couple of very important valves. We have what's called the mitral valve. The mitral valve is located right here, connecting the left atrium to the left ventricle, so that blood flows through. We also have the tricuspid valve on the right side. The tricuspid valve connects the right atrium to the right ventricle and allows that blood to pass through those chambers and get filtered into the corresponding veins and arteries. Now, if we talk about the very bottom section of the heart here, that is the apex of the heart. That's not labeled on your diagram, but you need to know that. Where the heart comes to a point is the apex, the inferior portion. Sorry, my handwriting's terrible there. Apex. And of course, we know this by now because of our chest x-rays. Coming off of that left atrium is that beautiful aorta with the aortic arch right here at the top. It's going to be that main giant artery connected to the heart. Right below that aorta, we have the pulmonary vein, which is right here. But we also, I'm sorry, not the pulmonary vein, the pulmonary artery, I apologize. The pulmonary artery is right here. The pulmonary vein is right down here connected to this section of the left atrium. And then we have the superior and the inferior vena cava. Superior vena cava is up off the top here, this blue portion, this blue vein. Inferior vena cava coming off the inferior portion of the heart down here. Those are going to be our main arteries and veins that are filtering all that blood throughout all the various systems of our body. Blood comes in, goes to the heart, filtered through, goes back out the heart, becomes oxygenated, of course provides that oxygenated blood throughout our body systems. As the blood becomes deoxygenated, it follows that path, that closed circuit system to come all the way back to the heart, become reoxygenated once more, and go back through the body in a continuous, endless cycle back and forth through the heart. Those pieces of anatomy I just named are the main ones I want you to know. Both atria, both ventricles, mitral and tricuspid valve, pulmonary artery, pulmonary vein, aorta, and the superior and inferior vena cava. I may have a beautiful diagram of a heart for you on your tests where you have to label some of this anatomy. Hint, hint. You will see that. Now, there are a lot more pieces of anatomy within the heart we could name, but this is the general parts of the heart that you need to know for registry purposes, so we're going to focus primarily on those. We're not going to go super detailed on that heart anatomy. Okay, so for the cardiac cycle, guys, so if you remember from last chapter, when we're actually calculating these cardiac cycles and reading them on our EKGs, we are focused on the ventricular contractions. So that first ventricular contraction, or I'm sorry, both those first ventricular contractions are going to be what we call the systole. That's why I put contraction in parentheses there for you. And then diastole is going to be when those ventricles actually relax. And we're going to get that measurement on the EKG sheet as well. So remember, when we're actually measuring, even though all this stuff is happening between the atrium and the ventricles, we're primarily focused on the ventricles for getting our measurements. So systole is the contraction of the ventricles. Diastole is the relaxation of the ventricles. And that's all done in a rhythmic fashion. Everything with the heart goes by rhythm. When it is out of rhythm, of course, that's when we have what we call, once again, arrhythmias that occur. We'll start specifying some of those specific arrhythmias as we move through this chapter here in a minute. While you're writing that down, I apologize, this PowerPoint is so yellow. I actually do not like the color yellow. I'm very upset that I chose yellow for this PowerPoint because it's hurting my eyes. So lesson learned to not use yellow on PowerPoints. Not a good idea. I didn't have time to change it though. I'm not a big fan of the warm colors. I like the cooler colors myself. Oh, maybe it woke some of you up though. Those bright colors made your eyes bug out along with your coffee. Maybe it was a good idea in the end. Who knows? All right, so we have two principal cell types found within our cardiac conduction system within the heart. We have what's called the working cardiac cells, also labeled as myocardium. That's the actual muscular cells in the heart that control the pumping, actually do the pumping action. And then we have the specialized neural conductive cells, which actually send the electrical signals, signaling that heart to actually pump and beat. So the working cardiac cells or myocardium are the workers, actually doing the action of pumping. The neural conductive cells are telling the heart to actually beat by sending those electrical signals to the heart in those different nodes that we talked a little bit about on the last PowerPoint. We're going to break those down a little further again in the next couple slides. So two principal cell types, myocardium and specialized neural conductive cells. Keep that heart regulated, keep it beating, keep it functioning properly in that homeostatic state that we look for. Of course, here we are looking at the nodes once again. We're going to define what these all do here on the next slide. The SA, AV node, bundle of His, and Purkinje fibers. just going to briefly talk about what those do specifically, what their main functions are. Okay, so for the SA node, the full name for that is the sinoatrial node, and that's essentially, in the simplest amount of terms, the pacemaker of the heart. It keeps the heart on pace through its beating. It works just like a pacemaker that we have implanted in our chest. In fact, that's why a lot of people have pacemakers implanted, because their SA nodes are not working as the natural pacemaker, thus they share the same name. The AV node, the full term for that would be the atrioventricular node, and that is going to be controlling the two atrial areas, top of the heart. It's going to coordinate them together to keep them in the right rhythm. So the AV node coordinates both the left and right atria to keep them moving in succession. The bundle of His is going to actually regulate the entire heartbeat, keeping it in rhythm. Then those Purkinje fibers, my favorite one to say, because I like the word Purkinje, it's just a fun word. Purkinje fibers are going to conduct the actual action potentials a lot faster than the other heart cells, keep that heart on pace. So its main function is conduction of action potentials. That's going into hormones and a lot more detailed stuff that you guys may remember back in college, where you talked about action potentials. We're not going to spend a lot of time on that because it gets very complex. But do know that Purkinje fibers control the action potentials a lot faster than the other heart cells. So the main conductors of those action potentials within the heart. So if any of those do fail, once again, that's why most people will have a pacemaker, defibrillator, or combination pacemaker defibrillator implanted into their chest with those wires going into the chambers, depending on what's not working. Those wires will be advanced to certain portions of the heart to connect to it and deliver those electrical impulses to do the function that perhaps SA node is not doing properly, or AV node is not doing properly. Bundle of His or Purkinje fibers. We have multiple ways and setups that we actually put these pacemakers and defibrillators into people's bodies, just to help control that function and keep everything regulated properly. Okay, so we do have specialized neural cells. They're, of course, going to actually transmit the actual electrical impulses. And once again, those neural cells do deliver actual electrical impulses to the heart. It keeps it regulated, keeps it in rhythm. It must stay in rhythm. Otherwise, we get, once again, what we call the arrhythmias. And arrhythmias can be very dangerous, very life-changing. It can kill people, of course. So we need those neural cells to work properly. And depending on what's going on, like I just said, we'll implant a device or give certain medications to ensure those neural cells are doing exactly what they need to do. They are independent of nerves or hormones, and they work on a function of what we call automaticity. Automaticity means they automatically do what they're supposed to do, free of other nerves and hormones. They're self-conducting, the specialized neural cells. Keep that nice rhythm like you see on that heart beating there on the side. It's got to keep that rhythm. Hopefully your heart's not going to skip a beat. You ever heard the term people's heart skipping a beat? We don't want our hearts to skip a beat because that can cause major issues to our surrounding body systems and or kill us, depending on the type of arrhythmia that does present. So we don't even know this is going on unless we focus on it. You can feel your heartbeat. It's just continuously going on that rhythm, never stopping, hopefully doing what it's supposed to do to keep your body in balance and keep you functioning correctly and keeping you alive essentially. All right, so we talk a little bit more about those cells. They are influenced by what we call the sympathetic and the parasympathetic nervous systems. That's controlled by the brain, by the way. The sympathetic and parasympathetic nervous systems, it keeps that heart regulated. And the abnormalities, as I've already stated, are what we call arrhythmias. The easiest way to remember that is we want the heart to be in a rhythmic state. If it's out of rhythm, it's going to present as a arrhythmia. The word rhythm is pretty much in that word. Easiest way to remember that. So abnormal rhythm would be an arrhythmia. Those cells are influenced by our sympathetic and parasympathetic nervous system, connected to our brain to keep everything functioning in a passive state, because we don't tell our brain to keep our heart beating. functions automatically, independently through that nervous system. Okay, so when we talk about cardiac membrane potentials, let's get into the EKG side of things a little bit here. We're measuring those electrical waves to make sure arrhythmias are not present. So we must know a little bit about the membrane potentials and the action potentials of what we're looking at on the actual readouts. So we'll hear a lot about depolarization versus repolarization. So depolarization, when you see that word, that's referring to the actual electrical changes to the cells that will cause the actual contractions that we'll be able to witness on the readout of that EKG sheet. When you hear repolarization, that's referring to the phase where those cells are actually beginning to relax. The electrical impulses are coming back, allowing the actual relaxation phase. This is all happening really fast as the heart's beating, keeping that rhythm. Depolarize, repolarize, depolarize, repolarize, and that rhythmic state back and forth. And that's what we see on those EKG sheets, repeating over and over again. When we look for those little inconsistencies, we want to all look the same, not have these weird spikes going too far up, too far down, spread out, very close together, where those arrhythmias do present themselves. Depolarization versus repolarization. The simplest definition is depolarization refers to contraction. Repolarization refers to the relaxation phases of that heartbeat cycle. Now let's talk a little bit about these waves again. We're going to go in a little bit more detail, but not super detail. We're just going to keep it more general overall. So when we look at an actual EKG sheet with the waves, I call them hills and valleys, by the way, but these wavelengths we're looking at, they're going to represent an actual electrical graphic display changes in the cardiac membrane potentials as a function of time. It is based on time. That's why we see the repetition through that EKG sheet. We're looking at it over a series of seconds or minutes. And that actual line that's going up and down that you see right there is what we call an isoelectric line. That's the actual terminology of what we're looking at there. That's an isoelectric line. We go from P to U on those intervals. We're going to define these a little bit, what's going on. The next slide here. So, of course, we do have all these waves, and I did put this slide in here again, guys, just to make sure that you know that I'll just say I will put an actual EKG sheet on your tests. They're not going to have these nice letters on them, but I'll put like an A, B, C, D, and I would ask, what is A? You would tell me that's the P wave. What is B? You would tell me that's the QRS complex, so on and so forth. So you do want to memorize this right here and be able to label what these actual waves, these spikes and dips, hills and valleys are actually representing. So it actually goes in order from P wave to QRS complex, T wave, U wave, and then we have what we call two intervals. The PR interval is found right here from P to R, and the QT interval is found from Q to T right here. These are different intervals doing different things. What I want you to focus on are the first four, which would be the P wave, QRS complex, T wave, and U wave. That's the most important ones to be able to identify when we as technologists are looking at these EKG readouts. P wave, QRS complex, T wave, and U wave. Don't have to worry about these segments. Focus on your letters in that QRS complex. So what's actually going on in these actual areas of the EKG? Well, when we talk about that depolarization, once again, we're depolarizing, allowing that heart to actually contract. That's occurring right here on our P wave, where we see that little spike with the P. That's the actual depolarization of our atrial muscle. Now, even though we're measuring things primarily from a ventricular standpoint, we can still see that atrial contraction as well on that EKG, and that's what's represented by the P wave right here. Now, of course, the atria contract first, followed by the ventricles. When the ventricles actually depolarize and contract, that's what's happening right here on the QRS complex. This is the ventricular contraction or depolarization right here in the middle of that graph. And then if you remember with repolarization, that's when the contractions have ceased and the muscles begin to relax. Repolarization refers to relaxation. That's represented right here by the T wave. And U is where everything resets once again, gets ready to contract all over again. So that T wave is the relaxation or repolarization of the ventricles and the atria. So you'll notice I didn't break all these down. These are the three main ones I want you to know as far as defining what they do. It's the most important three right there. P wave, QRS complex, and the T wave. So know what's going on all three of those, and also be able to label them on a graph that you see right here. Now, of course, when we talk about arrhythmias, when we start seeing things that look outside this average, for example, if this QRS interval was very spread out, if this R was at the bottom instead of the top, we know some serious issues are occurring. And we can actually identify the different types of arrhythmias based on how they present on that EKG readout. So as a technologist, yes, the atria also repolarize during the T wave. Yes, they do. So that's for atria and ventricles together. So whenever you're a technologist and you're in a room, for example, we have those monitors going across above some of our patients where we're seeing the heartbeat, like beep, beep, beep. I'm sure you've heard that beeping noise by now. You're seeing those little spikes. If you see something that looks really abnormal, once again, when it comes back to communication, you as a technologist, you're not going to ignore that. If you walked into a room and saw something going on that cardiac monitor, you'd of course want to immediately report that to a physician or nurse. Say, hey, I know I'm just a technologist here, but I want to bring this to your attention. And you guys see the cardiac output that's going on. I just want to bring it to your attention in case something's going on. You never know whose life you might save by doing that, because not everyone's always paying attention to this stuff. Even nurses, where it's their job to monitor that all day long, can miss these little details, which is why we all work together as a medical team, medical staff. I myself, I've caught it a few times myself in rooms, and I've told nurses and doctors just to bring to their attention. They say, "Thank you, I really appreciate that. We're going to check it out right away. We're going to up their medication. We're going to do what we need to do to fix that." Or, "That's totally normal, but thank you for bringing it to my attention. We already knew." Hey, you can never be too thorough. Never be too thorough for saving people's lives and helping them out. So what are some of the questions that we're going to ask when we see these EKG readouts? These are the most normal questions most people will ask if they're an actual EKG tech or a nurse. Not so much what you're going to do, even though you need to be able to identify that should you see it in the room. These are the 5 most asked questions, and those include, is that rhythm regular versus irregular? Are all the QRS complexes specifically similar? Or are they too narrow? If they're very narrow, that's a very big problem. If they're too wide, that's also a problem. Are all of our P waves similar? And are those PR intervals normal? We're going to look at how they look like on those readouts. Is the actual rate normal? Or is it extremely fast or extremely slow? And do those waves and complexes actually proceed in a normal sequence? Or are they actually abnormal, thus diagnosing that patient with what we call the arrhythmia? So those are the 5 most asked questions when it comes to actual EKG analysis. Those technologists will ask themselves when they're looking at those readouts, physicians as well. They'll be asking all these questions. And they develop an eye for it really fast. They can see it from a mile off, just like you guys will eventually be able to look at an x-ray and see a fracture from 2 miles away. These physicians, nurses, and technologists that do the EKGs learn how to identify those specific questions very quickly and report it accordingly. So the most common arrhythmias, I have them all listed for you here. There are a lot more than what's listed here. These are the most common types of arrhythmias. Of course, bradycardia, we've talked a little bit about that one in the past. That's referring to a very slow heartbeat. Versus tachycardia, that's when the heart's beating very fast, very rapidly. Fibrillation, a lot of people mix this up. This is not exactly referring to a fast heartbeat. It actually refers to when the heart actually begins twitching and quivering irregularly. It's not actually beating at all, it's just twitching in place. It actually looks like it's twitching, by the way. PVC is a flutter or an out of rhythm heartbeat. Ventricular tachycardia is similar to tachycardia, but it's actually referring to only the ventricular area specifically, And that's a very fast or improper electrical activity found in the ventricles only, not the atria. Tachycardia at the very top there refers to the atria and ventricles together. Same with bradycardia. Ventricular tachycardia only occurs in the two ventricles. We have a very fast contraction occurring. Ventricular fibrillation, same as the fibrillation we defined at the top, same concept. When you just see fibrillation by itself, that quivering is happening in the entire heart. Versus ventricular fibrillation, that's that rapid, irregular quivering only in both of the ventricles, or one or the other. It's actually twitching and quivering in place. And then asystole, of course, that would be the worst one of all. That's complete cessation of the electrical activity. The heart is not beating at all. It stops beating completely. Asystole. Did you have a question, Aurora? I saw your hand go up.
I did. You said that in ventricular fibrillation, it only happens in the... I didn't get that last part.
In the ventricles only, the left and right ventricles, which is why it's ventricular fibrillation. If you see fibrillation by itself, that's referring to the entire heart quivering and twitching. Ventricular fibrillation would only be occurring on those two ventricles on the inferior portion of the heart as they contract. They're twitching and quivering all over the place. And asystole, if that does happen, they're going to start getting the defibrillators out, shocking that heart, trying to get it back beating, and or doing open heart surgery to try to save that person's life. That obviously would be the worst case scenario right there, that asystole, total cessation of electrical activity. Once again, those are our most common arrhythmias. This is not all of our arrhythmias. There's actually quite a few more listed out there than that, including the condition my wife has, which is called long QT syndrome, which is a very rare condition.
Did you tell them the story with the doctor and your wife yet?
Not yet, but I was getting there. Not yet, but I was getting there. That's coming up. All right, so that's just showing you a little bit about what that bradycardia versus tachycardia actually looks like in comparison to a normal heartbeat. We want that nice, normal, regulated heartbeat. Bradycardia would be the slow heartbeat. Tachycardia would be the very fast heartbeat. And then, of course, fibrillation. I couldn't find a GIF of it. Fibrillation literally is an actual twitch and quivering where the heart, if you can see my hand does this, it actually twitches back and forth really quick. It can't get a full beat out, and it's not pumping that blood at all. And on the very bottom there, that's just showing you what my wife has. We have a normal QT interval here. This is what my wife's EKGs typically look like. It's what we call a prolonged or abnormal QT interval, and her heart has to be constantly regulated with a pacemaker defibrillator. When those prolonged QT intervals occur, her heart, her defibrillator will actually shock her heart to keep it regulated and pumping correctly. So since Tracy brought it up, well, I was going to bring it up anyway. So let me tell you guys my little story about my wife surviving her arrhythmia that she's dealt with her whole life. It's quite a spectacular, fascinating story. So whenever we got married, about 2 years later into our marriage, my wife had to go get her pacemaker leads changed out because she does have a pacemaker to keep her heart regulated. And if you know anything about leads, they actually go into the actual chambers of the heart, and they deliver those actual electrical impulses we talked about to keep that heart beating and keep it regulated. So people that have pacemakers and defibrillators, every few years, they have to go either get the battery changed or have those leads replaced because the leads do deteriorate. They get old, just like wear and tear on any electronic device. So she went in, it should be a routine surgery. She went in to get these leads changed. So as they were removing the old leads, they did not notice, as they were removing the leads, that there had been an excess amount of scar tissue that had formulated around the ends of the leads. So essentially speaking, it's almost like some little webs of scar tissue had actually attached to the leads in the chamber of her heart. So as they were removing the leads to replace them, they didn't see what happened, but those leads that were touching scar tissue actually ripped the inside of the heart. It actually, that scar tissue had actually attached itself all the way down into the inferior vena cava, and it ripped the walls of the inferior vena cava inside her body. So all of a sudden, everything was going off. All these monitors were going off. Her heart rate was going down really fast, and they didn't know what was going on. They quickly got some imaging in there, and they discovered that she was bleeding to death because she had a significant tear on her inferior vena cava. So they had to open her up very quickly, open heart surgery, because she was dying, essentially. She was going very fast. She was dying. They're telling me all of this. I'm having a complete meltdown, freaking out, because they just going to tell me, hey, your wife's dying. We're trying to save her, basically just like that. We're trying to discover what's going on. We don't know what the cause is. We'll keep you updated. So they had to open her chest up, and her heart was not beating. Her heart had completely ceased with beating, and they were actually performing CPR on her heart manually with their hands inside the cardiac suite. And this is in a cardiac suite, by the way. This was not a sterile area, so they didn't have sterile technique we talked about. This was an emergency situation. So they are doing CPR on her heart manually on top of her heart until they finally discovered where the tears were. In the meantime, this took over 30 minutes. She had CPR by hand directly on her heart for an excess of 30 minutes. If you know anything about CPR and the lack of heartbeat and blood flow, they say that long without blood flow and cardiac rhythm can cause permanent brain damage. So they finally found the tears. In the meantime, by the way, I didn't mention this, she lost her entire blood volume. And they had to have an emergency transfusion to transfuse blood into her. Only because they had just life flighted some blood of her blood type in at the very time of this happening. It was a miracle, as a matter of fact, that was even available. So they had to give her an emergency complete blood transfusion while doing manual CPR. In the meantime, they're telling me, sir, we think we have saved your wife's life, but she has had an excess of 30 minutes of CPR. She's lost her entire blood volume. She's had an emergency blood transfusion. We want to let you know that even though we've saved her life, there's a strong chance that she's going to be a vegetable and not have normal functioning brain activity. We're just going to tell you straight up, we're not sure if she's going to have any quality of life after all this that has occurred. So long story short, a lot more drama here and there. They did end up repairing the inferior vena cava, closing that off. They got the emergency blood transfusion into her body, closed her up. They had the heart regulated once again, but she was intubated. She was completely out, and they were monitoring her brain activity to see if there was any permanent brain damage. And she was completely unconscious for, it was about 3 days that she was unconscious and on life support and intubated. In the meantime, they're still telling me, sir, I just want to let you know, she's probably going to be a vegetable. She's not going to really get proper brain function because there's just been too much damage, too much blood loss. We just want to tell you straight up, sir, we don't know if she's going to have quality of life here. There may be some brain damage. We don't know if she's even going to wake up. Well, eventually, she did wake up. They started monitoring her brain function, and she had normal brain function. She had normal heartbeats, and they had her back balanced. And a lot more details here and there, but I'll end up talking for a whole hour about this. But one of my favorite parts of the story is whenever she was starting to get back to normal, and she was becoming conscious, even though she was still intubated. She was able to communicate, say hi, write stuff on a notepad to communicate. There was this anesthesiologist that came in, and my favorite part of the story is he was looking at me, he was looking at her, and he just had the most dumbfounded look on his face. He said, "This isn't possible. This just isn't possible. She can't be communicating. She shouldn't be conscious. This doesn't make scientific sense. She can't do that." And he started getting mad. Like, this just isn't possible. This is not scientifically accurate. She can't have brain function. There's too much CPR, too much blood loss. And he gets really red in the face and walks out of the room while we're just kind of looking at each other like, okay, thank you for that wonderful assessment, Mr. Anesthesiologist. Well, she indeed did have brain function, and at the end of the story, she is, to this day, completely 100% okay with zero brain damage and perfect quality of life and a wonderful mom of 3 kids. And she did defy all odds against what they said, that she would not survive, that she would be a vegetable, and she proved them wrong. And I just love, my wife and I love proving people wrong, and she definitely proved them wrong. And she's a fighter, one of the strongest women I've ever known. She has endured a lot through her life, and nothing has slowed her down in the least. So I always say, we all come from different walks of life. We all have different belief systems, but I do say, if you don't believe in miracles, I married one, and she is a walking miracle, and she did defy all scientific possibilities and came through it quite nicely. So that's actually the first of 2 stories. I actually have a second story of during childbirth, but I will save that for the next chapter. I'll keep you in suspense because something crazy happened with that as well. She does, to give you a little preview, she likes to keep proving that she's a miracle and that she never stops, and she likes to prove people wrong and defy all odds. And she definitely did that with the second occurrence during childbirth. That I will save for a later date. So that's my wife's story of her first major tragedy in the hospital. She's a wonderful woman, very strong woman, and I hope you guys get to meet her one day. Definitely a walking miracle. Walking miracle. Okay, so this right here, guys, let me segue back into this after that story. When we're talking about arrhythmias on EKG sheets, guys, of course, on the top left here, we have what's called a normal sinus rhythm. That's what we want those EKG sheets to always look like. In comparison, you'll see 3 other arrhythmias. This is what we don't want to see. We don't want to see that heartbeat becoming very rapid, which you see on the top right here. That's that rapid tachycardia heartbeat. We have this QRS complex down here dipping way low. That tells us something is majorly wrong with this heart. It's a ventricular complex. And then atrial fibrillation, where that heart's actually twitching all over the place. That's what that would look like on actual EKG sheets. Excuse me. We do want this normal volume to present at all times, but they will be able to quickly see, as you can see in these sheets. I mean, just glancing on them, you can definitely see something's wrong. That's what's so great about these EKG readouts. We can very quickly identify there is a problem, get the proper medication or emergency equipment to our patients. Okay, so for treatment of arrhythmias, we do have all kinds of anti-arrhythmatic medications. No, you do not need to know them by name. Just know that we actually give medications to control these arrhythmias. Cardioversion therapy that we will actually perform on our patients to regulate those heartbeats. Of course, cardiac surgery, cardiac ablation, and of course the implantable devices, which would be a cardiac pacemaker or an implantable cardioverter defibrillator, simplified as an ICD, and also what we call a combination pacemaker defibrillator, which is what my wife actually has. She has a combination pacemaker defibrillator. If I can find it, I'll show you guys her old pacemaker. We kept it. After that crazy surgery that happened, they gave us the old one. I got it in a box somewhere. I'll show it to you. It's our little souvenir from that terrible incident that we have. It's cardiac pacemakers and ICDs to help control those arrhythmias. And that's what a defibrillator implanted into the skin would look like. This is the defibrillator device, by the way. It looks like a rectangle. Goes right in a flap of the skin on the chest, not actually behind the muscle. It's on top of the muscle, by the way, right under that first layer of skin. And these are those leads I just talked about. They go through the subclavian vein all the way down into the chambers of the heart. And depending on what node is not working in the heart, where that electrical activity is not working properly, we're going to advance these leads to where they need to be to help deliver those electrical impulses should they not be working correctly to keep that heart on beat and in rhythm. To give you some perspective here, guys, what I just talked about, what happened to my wife, these are the leads right here. She has leads in all chambers of her heart, by the way, because her heart just is messed up. She's got a real crazy arrhythmia. And that scar tissue had developed around this lead right here, guys. This is the inferior vena cava, and the scar tissue had attached itself all the way down into the inferior vena cava. So when they pulled this lead back, it ripped the inferior vena cava walls, and that's why she started bleeding out to death and lost all her blood volume. So that's a little perspective of how that went down. But these do deteriorate, and that's why we have to get these leads replaced, and of course the batteries as well. In fact, we were joking the other day. She's due to go to the hospital next year to get her batteries changed out of her device, and we're like, oh God, let's pray something doesn't happen this time. Because I swear every time we go in, something crazy happens. We don't want to jinx it, but it seems like we never can avoid drama. And you'll see what I mean when I get to that other story that happened during childbirth. That's another great story coming for you guys. I'll keep you in suspense on that one. And this is what a pacemaker will look like. So the defibrillators are rectangular shaped. The pacemakers are more circular shaped. And my wife does have the combination one. Hers looks like a box. Same exact thing though, guys, with pacemaker. Those leads go into the subclavian vein, down into the chambers of the heart where that heartbeat is not occurring correctly. And it can go into the atria, the left side, ventricle left side as well. It all depends on where that heart's going to beat properly. We're going to put those leads in there to help regulate that heartbeat, deliver those electrical signals properly, keep it on pace to help prevent those arrhythmias that do present in our patients. So in conclusion, guys, yes, that is the conclusion. I told you it was a very, very short chapter. Not a lot to go through. So purely the assessment of the heart's ability, we're doing those electrical reads using that electrocardiograph, which can be simplified to EKG or ECG. This will give us a very thorough understanding of the cardiac cycle and help us to identify arrhythmias quickly, accurately, and efficiently. When we do have abnormalities of the heart, that's an interference with the actual neural conduction systems. That's what actually causes those cardiac arrhythmias because they're not delivering the proper neural electrical signals. And all those treatments of arrhythmias are based on the severity, the location, and whether the medications and or devices and or surgeries are the best means of helping to bring that arrhythmia to a normal state. Keep us regulated, keep us homeostatic, keep us in a state of equilibrium overall. And that is the conclusion of chapter 16. Like I said, very short chapter, not a whole lot of new information, but the previous chapter does have a lot of information. So put two and two together. Most of your test will be composed of chapter 15, but I'm going to throw some of the 16 in there as well. This will be a 2-chapter test on Friday. Are there any questions about 15 or 16? Any questions about the test or any questions in general, guys? Anything I can answer for you? Feeling good for our test on Friday? So do closely look at that information, guys. There are a lot of numbers in the previous chapter. Focus on those numbers because you are going to see them. It's very important that we know those averages as far as heartbeat, diastolic versus systolic pressure. Go over the heart anatomy we went over today. You're going to see that. Go over those EKG readouts. Know where the P wave is, the U wave, the QRS complex, all that wonderful stuff. Be able to label that. And of course, be able to define all the terminology we went over. There's a lot of vocabulary found in these 2 chapters that we just went over. So that test will be on Friday. If there aren't any more questions, we're done, guys. If there's any questions at all, if you think of any questions, please let me know. Send me a text, send me an email. And you get a little extended break today, guys. Go rest your brain a little bit, get some more coffee, which I'm about to go do myself. Get you some more coffee, enjoy yourself, and I will see you guys